Welcome everyone. In this video we shall be talking about congenital adrenal hyperplasia and discuss all the important questions related to it. Okay. So moving on to the first question. Which of the following mechanisms best explains adrenal hyperplasia and congenital adrenal hyperplasia? Okay. So what happens in congenital adrenal hyperplasia? It is an autosomal recessive disorder. Right, over here we have deficiency of the enzymes that are required for synthesis of adrenal hormones. Right, required for synthesis of the adrenal hormones. Right, as a result of which there will be decrease in the feedback inhibition. Of ACTH in the pituitary. Okay. And this would result in excess of ACTH and congenital adrenal hyperplasia, and this ACTH is responsible for the hyperplasia of the adrenal cortex. Okay. So direct tropic effect of excess cortisol, no, this is a false statement. First of all, we do not have excess cortisol, we have reduced cortisol and CAH, right? And moreover, even if we have excess cortisol leads to adrenal atrophy. And not hyperplasia. Chronic ACTH stimulation secondary to cortisol deficiency, yes, this is our correct answer. Accumulation of steroid precursors causing gland enlargement, no, steroid precursors do not cause gland enlargement. Then excess angiotensin 2 mediated adrenal growth, see, angiotensin 2 can have some trophic effect on zona glomerulosa, only the zona glomerulosa, not the other ones, and it does play a very minor role, Okay. So option B should be a better choice. Okay. Moving on to the next question. Which of the following statements regarding genetics of congenital adrenal hyperplasia are true? Okay. CYP21A2 gene is located on chromosome 6. This is an extremely factual statement. Yes, this is a true statement. This gene is responsible for synthesis of 21 alpha hydroxylase enzyme. Right. This is the most common enzyme to be deficient in congenital adrenal hyperplasia. Right. Moving on to the next option, that is gene conversion with pseudogene is common. Yes, this is a true statement. What happens then? This is actually the reason why 21 alpha hydroxylase is the most common enzyme to get involved. Although there are multiple enzymes, right? At least 4 enzymes that are involved in congenital adrenal hyperplasia, of which 21 alpha hydroxylase is much more common than that of the other ones. Because of this particular reason, what happens? There is a homologous pseudogene. Called the CYP21A1P. Okay. And this is just adjacent. to the CYP21A2. Okay. So what happens over here during meiosis? There is an unequal crossover. And this unequal crossover is known as this gene conversion with pseudogene. This unequal crossover, right, results in acquiring this pseudogene instead of the A2 version. Okay. So what happens? This CYP21A2 is capable of producing the adequate amount of hormone, but this pseudogene is not efficient that much, as a result of which we would get decreased production. Of 21 alpha hydroxylase enzyme, resulting in congenital adrenal hyperplasia. That's why 21 alpha hydroxylase deficiency is so much common. Okay. The severity correlates with residual enzyme activity. Yes, this is also a true statement. Of course, severity should correlate with the residual enzyme activity. And point mutations are most common defect. No, that's a false statement. This gene conversions lead to a missense mutation. Which is most common. Okay. So the answer should be A, B and C. Option C should be our answer. Okay. Moving on to the next question. Match the following enzyme defects with the accumulated hormone. Now answering this question requires a knowledge of the steroidogenesis pathway. So let's first have a look into the steroidogenesis pathway. Okay. So first we all know that we have cholesterol. Okay. From the cholesterol, with the help of those side chain cleavage enzyme, cholesterol desmolase, everything, we have this pregnenolone. From pregnenolone, in the presence of 3-beta hydroxysteroid dehydrogenase, we have progesterone. Okay. From progesterone, in the presence of 21 alpha hydroxylase, we have 11 deoxycorticosterone. ठीक है. Now from 11-deoxycorticosterone in the presence of 11-beta-hydroxylase we have corticosterone, and in the presence of aldosterone synthase we have aldosterone. So this whole pathway occurs in zona glomerulosa. ठीक है, the zona glomerulosa of adrenal cortex. ठीक है. Now this pregnenolone can be acted by an enzyme called 17-alpha hydroxylase. Right, 17-alpha hydroxylase forming 17-alpha hydroxypregnenolone. Similarly, progesterone with the help of the same enzyme can form 17-hydroxyprogesterone. And since 3-beta-hydroxysteroid dehydrogenase can convert pregnenolone to progesterone, similarly 3-beta-hydroxysteroid dehydrogenase can convert 17-hydroxypregnenolone to 17-hydroxyprogesterone. ठीक है. Now this 17-hydroxyprogesterone now similarly will be acted on by 21-alpha hydroxylase to form 11-deoxycortisol, and similarly by 11-beta hydroxylase would form cortisol, and this whole thing occurs in zona fasciculata. ठीक है. And now next, with the help of the enzyme something called 1720 lyase, this will be converted into DHEA, dehydroepiandrosterone. Right. And similarly progesterone, 17-hydroxyprogesterone with the help of the same enzyme 1720 lyase forms androstenedione. And again with the help of 3-beta-hydroxysteroid dehydrogenase, right, this DHEA can be converted into androstenedione. ठीक है. And this androstenedione with the help of several enzymes like aromatase, like 5-alpha reductase, right, will be forming our estradiol will be forming our testosterone, will be forming dihydrotestosterone, and all the sex steroids. ठीक है. Now if we have a look into this, match the following, right, for accumulated hormones, right, 21-alpha hydroxylase, right, 21-alpha hydroxylase, what happens? Now this 21-alpha hydroxylase, now this enzyme is deficient. ठीक है. Now when this enzyme is deficient, so this pathway is blocked. ठीक है. As a result of which there would be accumulation of progesterone and 17-hydroxyprogesterone. ठीक है. You can very well understand. That's why 21-alpha hydroxylase, there will be accumulation of 17-hydroxyprogesterone. Now 11-beta hydroxylase deficiency would block these two, so there would be accumulation of this 11-deoxycorticosterone and 11-deoxycortisol. So 11-beta hydroxylase would result in accumulation of 11-deoxycorticosterone. 17-alpha hydroxylase. Now 17-alpha hydroxylase would block this pathway. So this left pathway is the only one which is functional, right? This left pathway cannot move on to the middle and the right pathway. So this will go on. So there would be accumulation of aldosterone, there would be accumulation of corticosterone as well as 11-deoxycorticosterone, right? So of which corticosterone accumulation is most common. That's why 17-alpha hydroxylase we would get corticosterone accumulation, and 3-beta hydroxysteroid dehydrogenase, right? So this is involved, so this everything is gone. So this would result in accumulation of pregnenolone, 17-hydroxypregnenolone and DHEA, and this pregnenolone and 17-hydroxypregnenolone will be converted again into DHEA, so that would result in accumulation of DHEA. So it should be, D. ठीक है. So answer should be 1C, 2A, 3B, 4D. Option A should be your answer. ठीक है. So this steroidogenesis pathway is quite important to understand the accumulated hormone. ठीक है. Moving on to the next question. A 3-day-old male neonate presents with vomiting, dehydration, hyponatremia, hyperkalemia, hypoglycemia and shock, and the genitals are normal. What is the most likely diagnosis? Now this is the most important question of this topic. We need to differentiate between the 4 types of congenital adrenal hyperplasia based on the clinical feature. Now before we answer this question, we will learn this with the help of a mnemonic. This is a 3-step conceptual mnemonic. So let's begin with it. The first thing that we need to know is that adrenal cortex has 3 layers. We know this. Adrenal cortex has 3 layers from outside to inside. We can remember them as GFR. Okay, right? We have discussed this in our video on Addison's disease as well. You can have a look at that video as well. So G is zona glomerulosa, F is zona fasciculata, R is zona reticularis. Okay, GFR. The zona glomerulosa produces aldosterone, fasciculata produces cortisol, and reticularis produces androgens. Okay. Now, this aldosterone is responsible for increasing sodium for salt and water retention at the cost of potassium. So there will be a decrease in potassium. And due to the salt and water retention, we get an increase in BP. Okay. Next, cortisol would result in increase in glucose in the blood. And androgens is responsible for the sexual development. Now, first part of the mnemonic is assigning this GFR a number, that is 1, 2 and 3 respectively from outside to inside, G, F and R. Okay. So we are assigning 1 to aldosterone, 2 to cortisol and 3 to androgens, right? That is from outside to inside, 1, 2 and 3 respectively. This is the first part of the mnemonic. Moving on to the second part of the mnemonic. Second part of the mnemonic is the number sequence, right? First of all, we arrange the deficiencies in descending order. Right? 4 enzymes that can be deficient are 21 alpha hydroxylase, 17 alpha hydroxylase, 11 beta hydroxylase, and 3 beta hydroxysteroid dehydrogenase. These are the 4 things. We arrange them in a descending order: 21, 17, 11, 3. Now, the number sequence that we need to remember represents the deficient hormones. The number sequence is 1, 2, 2, 3, only 2, and 1, 2, 3. This is the number sequence that we need to remember to answer all the questions. Okay. 1, 2, 2, 3, only 2, 1, 2, 3. Okay. Now, these are deficient and the remaining ones will be a compensatory excess would be seen in the remaining one. 1 and 2, that is aldosterone and cortisol, that is zona glomerulosa and fasciculata are atrophied. So there would be hyperplasia of the third part, that is zona reticularis. So 3 will be present in excess. Over here 1 will be present in excess. Here both 1 and 3 will be in excess. Over here 1, 2 and 3 all are gone. So what happens? Due to this 3 hydroxysteroid dehydrogenase deficiency, we have seen that there would be accumulation of DHEA, right? So there would be excess of DHEA. There would be excess of DHEA. Now, this is the second part of the mnemonic that we need to remember: 1, 2, 2, 3, only 2, and 1, 2, 3. Now moving on to the third part, which is extremely conceptual. Right. Now we will try to decipher the clinical features. So over here 1 is absent. Over here in 21 alpha hydroxylase 1 is absent. So aldosterone deficient. So there would be low sodium and water at the cost, and there would be high potassium and decrease in BP, right? Because there is aldosterone deficiency. So we would get hyponatremia, we would get low volume status, that is dehydrated status, we would get hyperkalemia and hypotension. Okay. Next, 2 is also deficient. Remember that 2 is deficient in all the forms of congenital adrenal hyperplasia. So there would be decrease in glucose. And 3 would be in excess. Now 3 androgens are excess. Now if we talk about androgens, right, excess androgens in a male would cause precocious puberty, whereas in a female they would cause virilization resulting in ambiguous genitals. So this is these are the clinical features that we need to search for when we are talking about 21 alpha hydroxylase deficiency. Okay. Similarly, in 17 alpha hydroxylase, right, over here 1 is in excess. 1 is excess, which means there would be increased salt and water retention. There would be low potassium and there would be increased BP. So hypokalemia and hypertension. Okay. 2 will be absent, 2 will be less, so decreased glucose, hypoglycemia, and over here even 3 is absent. So in a male we would get ambiguous genitals due to lack of androgens. Whereas in a female, if we talk about a female, in a female everything will be normal till puberty, but after that the sexual development fails. Because even females require androgens after puberty, right, for sexual development. Okay. Moving on to the next one, that is 11 beta hydroxylase deficiency. Over here over here only 2 is deficient, so 1 is excess. So it will be similar to that of 17 alpha hydroxylase, right? There would be increase in sodium water, so there would be hypertension and hypokalemia, my bad. 2 will be deficient as usual, so we would get hypoglycemia. And 3 is again excess, so it would be similar to that of 21 alpha hydroxylase, right? That is, in males you would get precocious puberty, whereas in females you would get virilization and ambiguous genitalia. Okay. And finally over here 1, 2, 3 all are deficient. 1 is deficient, so it would be similar to that of 21 alpha hydroxylase. 21 alpha hydroxylase, right? Dehydrated condition, right? Hyponatremia, hyperkalemia and hypotension. 2 is again deficient, so we would get hypoglycemia. And with respect to 3 is deficient, but there is excess accumulation of DHEA, and this DHEA has mild androgenic property. This DHEA has mild androgenic property, as a result of which this mild androgenic property of DHEA is not enough for male but is a bit excess for female. As a result of which in males also we get ambiguous genitalia. This is due to lack of adequate androgens, and females also we get ambiguous genitals. Why? Because DHEA has androgenic property due to this excess accumulation. So this accumulated DHEA is not enough for a male but is excess for a female. Okay. So this is all that we need to know regarding the clinical features to differentiate between these 4 diseases, these 4 categories of congenital adrenal hyperplasia. This is enough. Just remember this sequence of 1, 2, 2, 3, 2 and 1, 2, 3. We will have a look into its application in a few more questions, right? That will make it more clear. Let's try to answer this question with that knowledge. Excuse me. A 3-day-old male neonate, vomiting, dehydration, hyponatremia, hyperkalemia, hypoglycemia. See, dehydration, hyponatremia, hyperkalemia, everything suggests of aldosterone deficiency, which means that the one component is absent. Hypoglycemia, which means that 2 component is also absent. 2 component is always absent in a CAH. Okay. And genitals are normal. In a male, the genitals are normal, which means that yes, of course, even if 3 is in excess, a male would have normal genitals. So it is 1 and 2 absent and 3 excess. So this suggests us that the diagnosis will be 21 alpha hydroxylase, right? We have read that 1 and 2 is deficient and 3 is excess. Similarly, 2 and 3 deficient and 1 excess would be 17 alpha hydroxylase. Only 2 deficient, 1 and 3 excess would be 11 beta hydroxylase deficiency, and all of them are deficient 3 beta hydroxysteroid dehydrogenase deficiency. Just remember the sequence of 1, 2, 2, 3, only 2, 1, 2, 3. Okay. Moving on to the next question. Right. Now a 7-day-old female neonate presents with vomiting, dehydration, hypotension, hyperkalemia, hyponatremia and ambiguous genitalia. What is the most likely biochemical profile? Even over here, 1 is absent because aldosterone deficiency. That's why we are getting hypotension, hyperkalemia, hyponatremia. 2 is always absent in congenital adrenal hyperplasia. And in a female neonate, we are getting ambiguous genitalia. That is excessive androgenous there. So 3 is excess. So again, our diagnosis would be 1 and 2 deficient, 3 is excess. So it would be 21 alpha hydroxylase deficiency. So what is the biochemical profile? Let's have a look into the option. Increased cortisol, no. Increased 2 is always. Cortisol is always reduced in all kinds of CAH. So this is a false statement. Even ACTH will be increased in all varieties of congenital adrenal hyperplasia. So decreased cortisol, yes, because 2 is deficient. Increased ACTH, in all cases we get increased ACTH because of lack of the feedback inhibition. And increased androgens, yes, because of this excess 3. So option B should be our answer. Decreased aldosterone, yes, we do get decreased aldosterone, but decreased renin is the false statement, right? As a result of decrease in aldosterone, we get increased renin. We get increased renin in 21 alpha hydroxylase deficiency. Okay. And increased BP, no. Increased BP is a false statement. Okay. So option B should be our answer. Moving on to the next question. Which parameter differentiates between simple virilizing from salt wasting CAH? Remember that whenever only CAH is mentioned, it is almost always 21 alpha hydroxylase deficiency. Okay. Now 21 alpha hydroxylase can present as 2 forms. Right, both of these can be seen in 21 alpha hydroxylase deficiency. Remember that this 21 alpha hydroxylase deficiency can present as 2 forms. One is simple virilizing type, and second is a salt wasting type. As the name suggests, salt wasting type will have decrease in aldosterone, severe decrease in aldosterone, right? Whereas in simple virilizing type, there would be only a mild decrease in aldosterone. As a result of which, the renin levels, as a result of which the renin levels are normal in simple virilizing type, whereas they are very much raised in salt wasting type. Okay. This differentiation is completely based on the severity. Okay. That's why we can differentiate it with the help of plasma renin activity. ACTH levels will be increased in both of them. Serum cortisol will be decreased in both of them. 17-hydroxyprogesterone, again a marker of 21-alpha-hydroxylase deficiency, will be raised in both of them. In order to differentiate between the two varieties of 21 and alpha-hydroxylase deficiency, we need to look for renin. Normal renin levels means simple virilizing type, and increased renin means it's a severe variety, there will be salt wasting form. Okay. Moving on to the next question. Now, hypertension in 11-beta hydroxylase deficiency is due to excess. Now, for this, we move back to the steroidogenesis pathway. Over here, you can see this 11-beta hydroxysteroid dehydrogenase pathway. Now, this left side, this zona glomerulosa, this aldosterone wala sequence is responsible for increasing the blood pressure because of salt and water retention. Yes, aldosterone can do that. Corticosterone can do that. Even 11-deoxycorticosterone can do that. But since there is 11-beta hydroxylase deficiency, your corticosterone and aldosterone cannot form, and there would be accumulation of this 11-deoxycorticosterone. So this would be responsible for the hypertension in 11-beta hydroxylase deficiency. Okay. So our answer over here would be deoxycorticosterone. Okay, due to accumulation, due to excess accumulation. In physiological levels, it won't cause hypertension, but due to excess accumulation, that can trigger hypertension. Okay. Moving on to the next question. Which findings favor 11-beta hydroxylase deficiency over 21 hydroxylase deficiency? Now, let's have a look. We all know that 21 hydroxylase deficiency is 1, 2 absent, and over here 3 would be excess, and 11-beta would be 1, 2, 2, 3, and 11 is only 2. So only 2 would be deficient, 1 and 3 would be excess. So what is the prime difference over here? Prime difference is aldosterone is high over here, aldosterone is low over here. This is the prime difference between these two. In 11-beta hydroxylase deficiency, aldosterone is excess. So hypertension, yes, we do get hypertension due to excess aldosterone, excess salt and water retention. Hypokalemia, again due to excess aldosterone. Low DOC, no, we just read that due to 11-beta hydroxylase deficiency, there would be accumulation of 11-DOC or deoxycorticosterone, right? So low DOC is actually a feature of 21-alpha hydroxylase deficiency, not of 11. And virilization is due to this 3 component, and 3 is excess in both of them. So again cannot differentiate. Okay, so our answer should be A and B. Okay. This sequence can help you answer most of the questions, rather all the clinical feature related questions of congenital adrenal hyperplasia. The sequence of 1, 2, 2, 3, only to 1, 2, 3. Okay. Moving on to the next question. Right, another application of the sequence, right? Phenotypic female with 46XY karyotype, hypertension, hypokalemia, absent secondary sexual characteristics, most likely as a deficiency of hypertension, which means that 1 is in excess. Okay. Right, 2 is always low in all congenital adrenal hyperplasia, and she's a female, and secondary sexual characteristics are absent, which means that the androgens are deficient. Okay, which means 3 is also absent. So 2, 3 is low and 1 is in excess. So the sequence would be 1, 2, 2, 3. 2, 3 would be 17. 17 alpha hydroxylase should be our answer. Okay. So with this sequence, we can answer all the clinical feature questions. Okay. Moving on to the next question. 3-beta hydroxysteroid dehydrogenase deficiency is characterized by. So this is the last one. So 1, 2, 3, all of them are absent. Then there is increase of DHEA. Right. Elevated pregnenolone, yes, we have read that during the steroidogenesis. This is rather the accumulated hormone. We can go back to that steroidogenesis step. Right. The 3-hydroxy-beta steroid dehydrogenase is absent, so there would be accumulation of pregnenolone, 17-hydroxypregnenolone and DHEA, and the accumulated pregnenolone also converts into DHEA. So ultimately we would get an accumulation of this DHEA. Okay. Now moving on to this next option, which is salt wasting. Salt wasting will be there in 1. Yes, this is due to, because the 1 component is absent, we would get salt wasting. Ambiguous genitals in both the sexes. We have discussed that due to DHEA has mild androgenic property, but it is not enough for males, but is excess for females. I'm so sorry, Yola. Just a second. I'm just sorry for the cut. Right. So excess DHEA. DHEA has mild androgenic property, which is excess for a female but not enough for a male. That's why we get ambiguous genitals in both the sexes. Normal mineralocorticoid synthesis, no, that's a false statement because the one component is absent over here. So A, B and C should be our answer. Option C should be our correct statement. Okay. Moving on to the next question. A 6-day-old newborn is brought to the emergency department with poor feeding, vomiting, dehydration and lethargy. On examination, the infant is hypotensive and has ambiguous genitalia. A CECT of the abdomen is shown in the image below. Which of the following is the most likely diagnosis? In the CECT, we can very well appreciate this bilateral adrenal enlargement. Bilateral adrenal enlargement. Okay. And also appreciate the lobulated or the cerebriform as classically described. Cerebriform appearance. This lobulated and cerebriform appearance of the adrenal gland, especially in a newborn, is very much characteristic of congenital adrenal hyperplasia. Moreover, even the clinical features are suggestive of congenital adrenal hyperplasia. Now, if we try to apply a mnemonic, the number sequence over here, see, we can very well appreciate 1 is absent because of dehydrated state, right, and hypotensive state. 2 is always absent, right, and we have ambiguous genitalia, but the sex is not mentioned. Now, let's consider both the cases. If he or she is if he is a male with ambiguous genitalia 1 and 2 absent, male ambiguous genitalia 1 and 2 absent, which means that there is low androgens as well. So 3 should also be deficient, right? In that condition, it would become 3-beta hydroxysteroid dehydrogenase deficiency. But if the newborn is a female, 1 absent, 2 absent, and in a female we are getting a ambiguous genitalia, then 3 must be positive, right? There must be excess androgen. So in that condition, it would become 21 alpha hydroxylase deficiency, right? So with the help of clinical features, the clinical features you will never get wrong with that sequence of 1 2 2 3, only 2 and 1 2 3. Okay. So moving on to the next question. Best screening test for CAH in newborn screening programs. Remember that when we screen congenital adrenal hyperplasia, we screen only one enzyme deficiency, which is 21 alpha hydroxylase, because that is the most common one. Okay. And what is the accumulated hormone over there? We all know that it is 17 hydroxyprogesterone. That is accumulated. So that is the one that we use for screening tests. Okay. Moving on to the next question. False positives. False positives in newborn CAH screening are seen in prematurity. Yes, we can get false positive. Why? Because the adrenal enzymes are immature. Adrenal enzymes are immature, and we can get deficient. Enzymes over there. Deficient, at least the functions will be deficient for those immature enzymes. In stress, yes, in stress there will be excess activity of this HPA axis, and there will be increased ACTH, and increased ACTH mimicking congenital adrenal hyperplasia. Okay. Low birth weight, yes, low birth weight we can link to prematurity. We can link it to prematurity. That's why we can get false positive results. And sepsis, again we can link it to stress. Even in sepsis we would get that because it is a condition of increased stress. So there would be excess ACTH and mimicking congenital adrenal hyperplasia. So the answer should be option D. All of them are correct. Okay. Moving on to the next question. Excuse me. Management principles of classical CAH. Management principles of classical CAH is nothing but a 21 alpha hydroxylase deficiency. Okay. So over here 1 is deficient, 2 is deficient, and 3 is in excess. Okay. So glucocorticoid replacement, yes, this is the cornerstone because 2 is always deficient. This is the cornerstone of CAH treatment, right? And we do it with hydrocort. Okay. So yes, A is required. Mineralocorticoid replacement, yes, this is again required because of, right, especially in the salt wasting type, right? And what do we use? We use fludrocort. Okay. Anti-androgen, no, we do not require anti-androgen therapy. Although 3 is excess, although androgen is excess in this condition, we do not use that. This is because the androgens decrease with adequate glucocorticoid therapy. With adequate hydrocort, the glucocorticoid therapy, the androgens start to decrease. We do not require an extra anti-androgen therapy for that. And surgical correction of genital ambiguity, yes, this is for virilized females. This is for virilized females. Yes, we do require D. So answer should be A, B and D. Option B should be our correct answer. Okay. Moving on to the next question. Which statements regarding prenatal dexamethasone therapy in CAH is false? Right, yes, of course, if CAH is diagnosed prenatally diagnosed, then we would administer dexamethasone, right? And has to be given before 9 weeks of gestation. This is a true statement, right? 7 to 9 weeks before gestation, because late treatment has no role. Late treatment has no role in prevention. And prevents virilization in XX fetus. Yes, this is a true statement. Again, we are talking about this 21 alpha hydroxylase deficiency, the most common variety, where we get virilized females, right? In order to prevent this virilization, we would provide this prenatal dexamethasone. Okay, and has to be provided before 7 to 9 weeks. Safe for all fetus? No, it is not safe for all fetus. Okay, first of all, males do not require it. Right? Because 21 alpha hydroxylase, right? If there is excess androgen in a male, it won't make any difference, right? We might get precocious puberty later, but it does not make much of a difference. But this excess steroid exposure can increase the risk of growth retardation, can increase the risk of growth suppression, right? And also the metabolic adverse effects that are associated with prenatal dexamethasone therapy. Okay, that's why we try to avoid in males and those who do not require it, right? And requires early genetic confirmation. Of course, yes, this is done via CVS, chorionic villus sampling. Okay, so our answer over here should be C. Okay, so with this we come to the end of our discussion on congenital adrenal hyperplasia, right? Remember that over here the most important thing that we need to remember is that sequence, right? Because most of the questions are from clinical features. Only once in INI hormone accumulation was tested, where we do require the knowledge of the steroidogenesis pathway. Okay, so if you like this video, consider subscribing to my channel, and thank you for watching.